This is a 49-year-old male presented with left flank pain on and off since 6 months and fever on and off since 6 months. Sorry, 3 months.
Slides are not moving.
He had left flank pain on and off for the last 6 months, which was incidence in onset, leaking in nature, radiating to back, mild to moderate in intensity, aggravates on movement, no specific relieving factors. Fever for last 3 months, which was intermittent, low-grade episodes, not associated with chills, rigor, subsides with antipyretics, no history of burning micturition or any no history of lithuria, pyuria, hematuria. It was associated with frequent nausea with loss of appetite and weight loss, and no history of back pain, cough, no history.
So, Lalit,
Yes, sir.
yeah, what any more details you want, or what do you think at this stage?
Yes, sir. No more details, sir. Actually, it looked like my stone disease, sir, with infected hydronephrosis or pyelonephritis, sir. And GUTV, it can also be my third DD.
Excuse me, sir, slides are not moving in my videos.
No, we are moving the slide, so you will be only able to see the screen.
Okay, sir. Okay, sir.
Right. Now, so one is you said stone disease, second is GTB. Anything else?
Pyelonephritis, sir.
Huh?
Pyelonephritis.
Anything else?
Any malignancy, sir?
How do you explain that?
Sir, in locally advanced RCC, sometimes fever can also present, sir.
So, is weight loss, loss of appetite?
Yes, sir.
All those things, pain, is that all common in localized RCC? Usually they are incidentally picked up.
Yes, sir. Yes, sir. Usually they are incidentally picked up.
So in RCC, how do you explain the fever?
Sir, in paraneoplastic condition in which there can be fever also in RCC.
What substance is released that can cause fever?
Interleukin 6.
Tumor necrosis factor, all those things. Any else?
Yes.
So any other diagnosis? You have right now put stone, infection, GUTB, and RCC. Anything else?
Yes, sir.
The infection means all that.
Yes, sir. Yes, sir.
What else?
Lymphoma, sir.
Yeah, that is... no, we'll usually stick to urological. It can be possible, but let's go to the urological causes first, and then, lymphoma comes from somewhere else. Management is mostly by non-urology. We have not much role in it.
That's all, sir.
That's all. Anybody else wants to add something? Which is common urological condition.
XGP.
Yeah, XGP. You have flank pain, you have loss of weight, loss of appetite, fever, all that. So this whole thing can be fitting there. GUTB, again, because there is no lower tract symptoms. GUTB affects one side or both sides?
Mostly both sides, sir.
Yeah, it's always both sides. One side may be more affected than the other, but it is always both sides. And of course, there is no lower tract symptoms, so very unlikely. You won't be putting it in the top of your differential diagnosis.
Yes.
So, other than this history, anything else you want?
Any surgical history, any urological intervention?
No, not there. Any patient who has weight loss and all, you need to ask whether the patient is a smoker.
Yes, sir.
Of course, thinking in terms of malignancy, that history must come.
He is non-smoker, sir.
I mean, yeah. Okay, next.
Yes, sir.
Okay.
Any family history of tuberculosis?
No, not there. So, don't,
Yes.
if it is not there, not.
Yes. The examination.
See, in a patient who has pain from last 6 months, fevers in 6 months, it is very unlikely this patient would have kept himself at home without any evaluation or treatment. So, in your history, you should also ask whether he took any number of antibiotics, analgesics, was he admitted, was he evaluated. Sometimes all that would have been done, and because you didn't ask, he is keeping quiet. So you would expect a fellow who is having fever from 3 months to have taken some form of treatment. Okay, you said antipyretics, but definitely along with that, some courses of antibiotics would have been there. So treatment history is something which you are always missing. It has to come because that may change your interpretation of the reports if the patient has been already treated with various courses of antibiotics and all that. Anyway,
Yes.
proceed. See what is missing here?
Treatment history, sir.
No. We discussed that in the examination. What is missing?
Okay, sir. Sir, I cannot able to see the slides, sir.
This slide, examination slide, you are not able to see.
Yes, sir. I am also not able to see, sir.
Anybody else? Now, all of you. Anybody seeing the screen, or we'll share it again. Let's stop share. Okay. Now share it. Okay. Are you able to see now?
Yes, sir.
Yes.
Now we will.
Right. See, you saw the history. Now we are coming to examination. What is missing in this slide? So you said weight loss. You should always try to quantify the weight loss, whether it is more than 10%. If you have lost 1 kg in the last 1 year, that doesn't make any difference. So if you have a history of weight loss and the patient is aware of what was his weight maybe 6 months back, now if you have a record, you should record his weight.
Okay, sir.
Because if you don't measure it now, you will never measure it in the further course of your investigation. Okay. Yeah, you can see some tenderness there.
Yes, sir. Tenderness over left lumbar region and renal.
Again, the patient gave history of temperature, fever, so you should also record the temperature. See, all these things, even during your exam, these all will be kept where you are examining. I'm talking of the exams. So, if the patient is febrile, you have to record his temperature. Don't say, I didn't check all that.
Okay, sir.
So, all vitals have to be recorded. If weight has to be recorded, patient is stable, you can check his weight also. Anyhow. What else in the examination? Only tenderness.
Yes, sir.
So coming back to your 5 differentials, what is out or what is everything is still there, or you want to change?
Sir,
It's the same. I don't think your differentials will change examining based on this examination. Correct? Mass is not palpable, so still it can be all the differentials what you quoted. I don't think you said PUJ obstruction. You can add that also, because patient may be having a primary PUJ with secondary complications, which may be stone, which may be infection and other things. Okay, 5 to 6 differentials we are told. Anyhow, next, shall we go to the next slide? Yeah.
So hemoglobin is 7.6, sir. Counts are raised, total leukocyte count 15,900. Blood sugar is okay, he's non-diabetic. Urea create is also within normal range, sir. And in urine routine, sir,
Yeah, tell me what is worrying you in this slide.
First of all, total leukocyte count, sir. And
That's all.
rest things are also there, sir. Pus cells are present in the urine, sir.
No. What is worrying you in this slide? If you are a surgeon.
Hemoglobin's less, sir.
Yeah. So why is hemoglobin less? What does it indicate to you?
Any in malignancy also, sir, it can be less, sir.
It means there is there is a chronic illness.
Chronic condition, yes, sir.
Chronic condition, plus he has history of loss of appetite, loss of weight. So are we dealing with some metastatic disease, localized RCC and all that? Unless the patient has gross hematuria, it does not cause these constitutional symptoms of weight loss and other things. So are we dealing with some metastatic disease? Second is, why there are pus cells, but no RBCs? It can still be stone disease, but his creatinine is normal. So for you to have a stone disease and a low hemoglobin, there should be a component of infection or CKD, or the opposite kidney is less functioning or whatever. So stone disease with 7.6 is very uncommon. So something more serious condition is there in this patient. So again, tuberculosis is still possible because you have pyuria, but sterile pyuria. So there comes the point which I said. Was it treated earlier with any course of antibiotics? This you have to specifically ask, because the patient is having fever for the last 3 months. So you wouldn't expect a fellow who is having fever for 3 months to not been treated by antibiotics by any general practitioner, or he would have gone to a pharmacist and then taken some medicines. So that you should ask about. Okay, so what next you want to do?
Ultrasound scans.
Okay. See, in these patients, again, if there is weight loss, if there is low HB, you can do serum albumin also to look whether his nutrition, because if you are planning some surgical intervention, you need to know his albumin and all that. As such, he has low hemoglobin. So if you want, you can ask for peripheral smear. But once you go to ultrasound, other tests and all that, you may not be coming back to this. So you need to investigate why his hemoglobin is less.
Yes.
Okay.
In the ultrasound, sir, this left kidney, sir. The left kidney, sir, there are multiple hypoechoic areas, and some hyperechoic areas are also there with dirty shadowing.
See, otherwise, if whoever is making the slide, if the image is important, make it a full screen one slide. There is nothing, there is something I have to see on the liver image. If it is normal, we'll trust you. But the pathological slides, which are abnormal, you enlarge it and put it in single slide. Doesn't matter, the number of slides increases. But if you make it a very small, you will not be able to appreciate the details.
Okay, sir.
Okay, and it should be labeled. Now, I don't know whether the right, left, preferably labeled. It's so small, it's very difficult to make out what it is. I think it's the left kidney on the right side,
Yes.
top one. Okay.
So these multiple hyperechoic areas with the shadowing are there. Look like air in this left kidney, and sir, multiple hypoechoic areas are there in the renal parenchyma, suggesting of pyelonephritis.
Why you are thinking of air there? It looks like a stone.
Sir, this shadow is dirty, sir, with dotted appearance, sir. So it may be stone and maybe, sir, air also. But there are multiple areas, sir, of this hyperecholinity, sir.
You need to say about the size of the kidney, shape of the kidney,
I see.
the pellicalisal dilatation, whether the corticomedullary differentiation is maintained, and then the abnormal findings. Again, if the measurements are marked on this thing, fair enough. If it is not marked, sometimes you won't be able to. Of course, there is a scale on the right side. Always comment about the opposite kidney also, because that is important now. The lower down image. Is it the same kidney or opposite kidney?
I think it's same, sir.
Liver is seen, so either liver or spleen, whatever. Anyhow, otherwise we'll go to the image, the report. Next. Wait. More images. So, what else it can be other than you are thinking in terms of emphysematous pyelonephritis? I agree. What else it can be?
Stone, sir.
Stone disease, then?
And pyelonephritis, sir, because multiple hypoechoic areas were also there in the parenchyma, and there was loss of this corticomedullary differentiation.
So can it be
pyelonephritis, sir, chronic pyelonephritis?
So can it be tuberculosis?
It can be, sir.
How do you explain?
But in tuberculosis, we find calcifications also, sir. So maybe the.
Yeah, but usually you will see some calicial dilatation or the
pelvic calcium system
is not
visible.
It's not shown here, but anyhow, some calcifications are known. Can it be RCC? You said RCC.
RCC, sir, it's less likely, sir, because it is involving the whole kidney, sir.
Can you get calcifications in RCC?
Yes, sir.
So if your predominant finding is calcification or a stone disease, everything is possible. XGP is still possible. If there is a calcification, there can be stone in the XGP also. But again, you see there is no, the renal architecture details are not well made out, or he has not shown it. I don't know. Okay, what is the bottom left image? It's the same kidney, I think.
Bottom left image, sir. Yeah, sir, it's kidney, sir. Same kidney, sir. Left kidney.
Okay.
Yes.
So, we'll go to the report and then CT may be better. Yeah, next.
It's enlarged left kidney with loss of ecomorphology showing multifocal reflective intraparenchymal area suggesting of intrarenal air collection without hydronephrosis. There is evidence of left renal calculus 18 mm with localized left perirenal collection with organized debris and air measuring 30 into 19 mm. And right kidney has no findings.
So once there is air in the pelvic system, are you happy with the diagnosis of stone mentioned there?
Sir, stone and air both are there, sir.
No. What I'm saying is when you have a lot of air in the kidney, sometimes the kidney itself is not visible.
Yes, sir.
Okay. So that
Yes,
is
sir.
sometimes you should remember the sonologist will say he cannot make out the kidney itself. There is a lot of air in the
Lot
kidney.
of air. Yes, sir.
Correct. So everything about this case, including the stone, everything you should think it is doubtful unless you continue with the further imaging.
Further imaging will be required. CT scan.
Correct. Why I'm saying is you don't discuss about the management of this case with the patient till you have the finer details about this in the CT.
Yes, sir.
You are still thinking in terms of stone with emphysematous pyelonephritis, but it is better to see the details in the CT. Okay,
Yes.
next.
CT scans. In this X-ray KOB, sir, in the left side there are multiple stones are present, and
Is the exposure, extent, everything all right? Because if you directly go to the stone, what you are seeing, then you will never come back to the other findings which are there in the X-ray.
Sir, exposure to this exposure is okay, sir. Extent is also okay, sir. It is going up to the greater tuberosity lower and above it up to T12 vertebra, sir.
So you will be penalized. What should be the lower extent of the X-ray KUV?
Up to bilateral greater tuberosities.
What? Bilateral?
Greater tuberosities of the femurs.
No. See, we are not interested in the tuberosity. We are interested in knowing the symphysis pubis lower margin.
Yes.
You want to see any prostatic urethral calculus still there. Okay, we are not extending to the urethra, but the symphysis pubis lower margin should be visible.
Okay.
So you are telling some greater tuberosity. What will I do with the greater tuberosity? I am not interested in the fracture femur, neck, all that. But the lower margin of the symphysis should be seen above till T11.
Okay.
So with the availability of CT, nobody is interested in X-ray, but you said the extent is all right. That's why I said this is the lower extent is missing. What is the plate size for X-ray KV normally?
Sorry, sir. Forward.
You don't know.
18. Yeah.
18 is age for consent. Huh? This we asked you some time back also. Nowadays, all the X-ray plates are digital. It's not the film. But even then, the cassette has different sizes. And X-ray KV, we usually use 14/17 inches. Anyway. Right. When you ask for all this, what is the radiation received by the patient when he has X-ray KV? What is the units used? Do you know?
Millisieverts.
Good. So what is the units? What is the radiation to the patient?
I don't remember exactly, sir, but it's near about less than 1, sir.
Anybody? 0.7. Chest X-ray is the least.
7 times of the chest X-ray.
It's about 0.1 or something like that. Okay. So this KUB is usually 0.7 millisieverts. Okay, coming back to this. So the extent of the X-ray, lower limit of the X-ray KUB, the symphysis part is not seen. Okay, then what else?
In the left kidney region, there is a large stone.
Again, you're again still jumping to the kidney. You should always talk about the bony structures, whether there is any abnormality or it is normal. Then go to soft tissues, which is important, like the psoas shadow. Okay, if the psoas shadow on that side is not visible properly, that means there is an inflammatory mass on that side. If there is scoliosis on with the convexity towards the opposite side, it means there is inflammatory mass on the opposite side. So all these things are important. I mean, nowadays we may not be going into those details because of the availability of CT and all that, but these findings you should know. You cannot appreciate the psoas shadow on the right side. You should mention it, probably because of the bowel gas. At least the left side is visible.
We can appreciate the left side.
So don't jump directly to the whatever the obvious thing what you're talking. Always go by the complete description of the X-ray. You are not expected to say there is a stone in the radiopaque shadow in the left renal area, but you have to say this is X-ray KUB, the extent, the bony shadows, the soft tissue shadows, then the abnormality.
Yes.
That is, if a patient sees this, yeah, you will see that stone. You are describing like that. In exam, you are expected to speak like this. The left side, the right side renal shadow is not visible. The psoas shadow is now obscured by the bowel gas. All those things, findings, you should speak. Okay, coming back to your radiopacity. Now you tell.
There is a large radiopaque shadow, and with multiple small radiopaque shadows in the left renal area. So, look like multiple renal stones, sir. Or it can be calcification also, sir, in the renal parenchymal calcification, but we cannot appreciate all the X-rays.
See, what is large for me may be small for me, man. You should not be going in that way. What is the correct way of describing it?
By size, we can describe.
Yeah, always.
Yes.
Don't go by descriptive terminologies. Describe the size whenever possible. So that information everybody understands. If you say 3 by 2.5 centimeters, everybody knows, rather than saying small, big, large, whatever, descriptive terms. So describe the exact size. Okay. If you have a scale with you, keep it in your pocket and then measure it. Or roughly you can say it's about 3.5 centimeters, whatever. Yeah. So what else do you want to describe in that radiopacity?
Sir, sorry, what else other than this stone, sir?
In the stone only, what you have to describe. You said the size you have told. What else? It's like the size, number, position, location, density, everything you have to tell, man.
Yes, sir. There is a stone of size approx 3 by 2 centimeter, and probably in the upper in the pelvis, probably, but we can't be sure, sir.
Okay. What else?
And it's homogeneous, sir. There is no air foci inside the stone, sir.
No, your descriptive terminologies are very bad. See, when you are describing a stone, you should say at what vertebral level. Okay. So if I tell you if that radiopacity is at the level of T12, whatever, I think that is T12 or whatever. So you speak in terms of the vertebral level, always. So if you are unable to tell it's in the upper calyx, interpolar calyx, lower calyx, pelvis, definitely you should always say it is at this level, or vertebral level. If you have a ureteric stone, you say it is at L5, you say at S2, whatever, or at ischial spine level, at the VUJ, whatever, you need to always describe in terms of the vertebral level. So you said homogeneous, it is a dense stone. Now, when in a X-ray KV, what do you compare it with? Density. I'm not talking of CT. In a X-ray KV, what is there to compare?
Vertebrae.
Yeah. So is it equal or it is more dense than the vertebra? Is that what you can say? It is, in this case, it looks like more dense stone, a dense stone. So you are dealing with not soft stone like a uric acid, which may be partly radiolucent. It's not an infected stone. In the infected stone, you will have probably a central lucency, and it is also not a speculated stone. I mean, it may be details, but on the look wise, it's not looking obviously speculated. So it's not uniformly round or something which we describe it in secondary stone. So all these descriptions you should be able to tell over a phone. If I am listening to you, I have not seen the X-ray. You should be able to describe it that way.
Yes.
Right. So the kidney shadow on that side, is it the same size as the opposite side, or it is enlarged, or it is contracted? You can see the outline of the kidney.
And the left side, we can appreciate, sir.
No, you have other radiopacities, no?
Yes, sir. Multiple other radiopacities.
Yeah, multiple radiopacities in the lower pole, ranging from 3 mm to 8 mm, whatever. About measuring about 5 to 6 such radiopacities are seen in the lower pole region of the kidney. Okay,
Yes.
right. Okay, next we'll go to CT. So you have to improve your description.
Yes, sir.
Again, this is whoever is making the slide. If you put like this, it is very difficult to appreciate the details. Give one image, which is very important. You can take a picture. If you are having a PAC system, you can copy that particular image. If you are having a film, you take 1 or 5 images which are important. Otherwise, if you put the whole whatever 35 images in one picture, you have done the job, but to appreciate it in the screen, it's difficult. Okay.
This is a non-contrast CT, sir. In this, sir, the right kidney appears normal, sir, normal shape, normal corticomedullary differentiation, sir. Pelvic LG system we can appreciate in the right side. In the left side, sir, there is a large stone in the renal pelvis. In the left side, sir, kidney is enlarged, sir, and the shape is not reniform. It's about around spherical shape, and there is a stone in the center of this kidney, in the renal pelvis, maybe, sir, and multiple air locules are there in the left kidney, sir. And
see, anyhow, if you have all the images, see all that, and then start describing rather than speaking on one particular, yeah.
This is contrast CT, sir. in the right side, contrast uptake is okay, and in left side, the contrast uptake is less compared to right side, sir. And there is heterogeneous enhancement in the left side, sir. And multiple air locules are there.
So it is a RCC, you mean? Heterogeneously enhancing. When you use that typical word, heterogeneously enhancing, what is enhancing? I don't know. But
it is less because there are some areas where there is no uptake in the left kidney, and some areas in the periphery there is contrast uptake is present.
No. What I understood is that terminology what you use, heterogeneously enhancing, is used for a tumor.
Yes, sir.
So you are thinking of a tumor. This is a tumor?
No, sir. Air is there, sir, inside the kidney. More goes towards the pyelonephritis side, emphysematous pyelonephritis.
Lalit, wait 2 minutes, sir.
Yeah, sorry, I was in another call. So you want to finish seeing all the images? See all the images. That's all. Okay, now you describe. No, contrast image.
The left kidney is enlarged, sir, and there are multiple stones inside the left kidney, sir, with the large stone approx 3 by 2 centimeter in the renal pelvis, sir. And so multiple air locules are there in the left kidney and the renal parenchyma also, sir. And pelvic calyceal system we cannot appreciate, sir, is distorted. And in comparing to the right side, the left side, the enhancement is less, reduced enhancement in the left parenchyma, and some hypoattenuated area are also there in the left kidney, sir, where there is no contrast uptake is there. And in the last slide, slide in the CT urography, we cannot see any contrast excretions from the left kidneys.
Anyhow, your descriptions is of the image is very even in we saw it in X-ray KV. It's again in the CT. So you have to go step by step in your description. When you are talking about the kidney, you are using words like enhancement. The word that has to be used is uptake and excretion of contrast, corticomedullary differentiation. These are the terms used. You cannot use your own words and you will be ending up in trouble. Uptake of contrast, that is the word used. You are using enhancement. No. And you compare it with the opposite, probably an opposite normal kidney. The uptake of contrast is less in the left kidney compared to the right side. Even in delayed images, I am unable to appreciate the pelvic calyceal system. Depends on what timing they have mentioned, I am unable to appreciate it. This can be as early as 15 minutes, or if they have taken delayed films, then whatever details. There are multiple calculi in the left kidney. The largest in the pelvis is about 3 centimeter, 1.5. Multiple other stones in the lower pole. Again, I said 3 to 5 or 3 to 8, whatever mm in size. there is air in the pelvic system and in the parenchyma, and you have to go outside the kidney. What is happening when you have such an inflammatory process? What is happening to the perinephric area? Is there fat standing? Is there perinephric collection? All that should come. You are then are you able to see the ureter? The ureter, are you seeing the appreciating the renal vessels? Okay, is there any large hilar lymph nodes, which is possible in this case when there is so much of inflammation? If you are unable to appreciate, you should say, I am not able to appreciate the renal vessels at the hilum, the lymph nodes. All these are part of the description. So unless you have a thought process of what all I have to tell, in addition, the liver, spleen, because liver, spleen, pancreas, all other soft tissue, and even the bladder should not be forgotten. Most of the time you are stuck with the kidney, you don't describe the bladder. There may be obvious pathology there, the bladder may be small, whatever. So all this should come in your description. You cannot stop in between. Anyhow, so if your presentation, you are in which year now? First year?
First year, sir.
First year, yeah. So you just remember these are the thought process. You should include all these things in your description. Perinephric space, the ureter, the vessels, the lymph nodes, other organs, bladder, everything. If there is contrast in the bladder, you say there is contrast. Probably they have taken early and finished it. There's nothing in the bladder. No contrast in the bladder. But the capacity, everything looks normal. Okay, so what do you want to do now?
The kidney DTPA scan to assess the function of the kidney, and we can plan for nephrectomy, sir, left side.
See, the patient is having anemia. The patient is having, though his urine culture is sterile, he may be having active infection in there may be pus in the kidney. So you are actually telling straight away nephrectomy. In a stone disease, in a kidney which is infected, I would put it to simple ureteric stone. If you do a CT IVU, there may be no excretion of contrast at that point in time, but the kidney may be better functioning. So you deciding about the function in a system which is infected, in a system which is obstructed, is a wrong thing. You understand? You should always stabilize the patient by putting a PCN. So I would have expected you to say, I will start this patient on antibiotics. I will put a PCD or a stent, ideally a PCD, percutaneous nephrostomy. Of course, you tell the patient that the function is compromised. You may have to put a perinephric drain as well as a PCN. Reassess the function after a period of time and then take a decision. Because these kidneys can be good functioning if you take appropriate management. So don't jump and say, I will do DTPA and then do nephrectomy. It's a rule. Even if it's a ureteric stone, if it is obstructed, you drain it and then reassess the function. In fact, in a kidney, if a patient has pain during IVU, you may not see any excretion of contrast on that side. It doesn't mean the kidney is not functioning. So always drain the system, stabilize the patient, then reassess the function. Anyway, next we'll go there. So in your description also, if you have something like emphysematous pyelonephritis, you should be able to tell what class of emphysematous it was, whether there was air in the parenchyma or air outside the pelvic outside in the perinephric area. So those when you are talking about a thing, automatically all that should come. If you are describing a tumor, what is the nephrometry or like that? If you are talking of emphysematous, what is the staging? Staging means whatever that class or stage, whatever you want to say that. All that should automatically come. Small cat 1 cyst, what is that? Category 1, I think. Lower down. Okay. So what do you want to do? So that's what. Don't jump into the nephrectomy part. Always, I mean, he is actually not a fit candidate for nephrectomy. His hemoglobin is 7.6. He is having chronic infection, inflammation. So you have to stabilize the patient. He has not come in hypotension. He has not come in sepsis at this point in time. So you have to stabilize the patient and then plan. Yeah, agreed. He may require nephrectomy at a later date, but always reassess the function. So what is the clinical parameters to say that this patient is stable, unstable in emphysematous pyelonephritis? What are the risk factors?
Sir, thrombocytopenia, sir, and BP, pulse, and
Are you talking of the risk factors in emphysematous pyelonephritis? Do you know how many are there, or simply you are telling pulse, BP, something?
Sir, other than these clinical examinations,
No. See, the question is very clear. What are the 4 risk factors? I have told you there are 4 risk factors in patient with emphysematous pyelonephritis.
yes, sir. One of them is elevated serum creatinine, sir, and one is thrombocytopenia, and one is less patient is in shock, sir. BP will be less, sir, and altered sensorium, sir.
Yeah. Again, when you are answering, one is means that's a very wrong way of answering. Okay, you say altered sensorium, shock, thrombocytopenia less than 60,000. Okay, then renal failure more than 2.5. Of course, each studies have different levels. Some have taken 2, some have taken 2.5. But you should be able to tell some value. It is not that 1.4 is considered in any of the studies. So, right. So this patient, if you put it that way, he doesn't have, his creatinine is normal. He is not in altered sensorium. He is not in shock. And his platelets, it was not mentioned, but I assume it is also normal. So he has a good prognosis. Irrespective of the CT classification, whether it is, I think it is 2, that is, if the parenchymal gas is there, it becomes 2. If there is perinephric, it becomes 3. Now, yes. If there is no perinephric gas, it becomes 2. But irrespective of the the CT finding, it is the clinical parameters which decide which way we are going to do. So in this case, you will have to admit this patient, put a perinephric drain and a PCN, and you correct his anemia and other parameters, and then Hello?
Hello?
Yeah. Are
yes,
you able to hear?
Yes, sir. Yes, sir.
How will you reassess the function?
We'll repeat the investigation, sir, after 48 hours, after appropriate antibiotic and fluid administration, sir.
48 hours, you want to repeat everything? What do you want to decide at 48 hours, man?
So renal function, RFT.
Renal function was already normal. What do you want to assess? Why you want to repeat creatinine?
They are to checking, sir, if they are not deranged, sir, after.
So you are expecting it to worsen after putting a PCN?
Oh, sir, PCN. Actually, sir, I was not hearing in between, so I didn't know, sir. You were asking about PCN.
No. I have put a PCN. Now, today we have put it. What is
Yes,
your
sir.
plan? The parents, the family, I mean, whatever, everybody is asking, what next, doctor? So when do you want to reassess the function of that kidney? You know that the function is compromised in the contrast CT, what you have done.
So we'll wait for some time. We'll check the output of that kidney from the PCN, and we'll check for the specific gravity of the urine from the left kidney if it is coming. And after some weeks, sir.
You have to be specific, no? At what time you will assess the function? That's a specific question. I'm not asking. Huh?
4 weeks, sir.
Why 4 weeks? Because the patient will get next month's salary?
I don't know.
So you should have a scientific reason to tell any particular answer, no? You cannot say sometime, some 4 weeks. What is the basis? Why you are saying 4 weeks? Why you are saying 2 weeks? Why? You should have an answer.
Sir, sorry, sir. Sir, we have a class. We have OT, sir.
Yeah, sure.
Thank you, sir. Thank you.
Okay, right. Close it.